everyone. Hello, and happy Friday. It's the Friday before the Christmas holiday. So, welcome for those of you who are joining us today. I just need a few more seconds hopping on our stream account for Instagram and YouTube so we can have everyone who wants to join be able to join us today. And you guys can see what there we go. And I think we are rocking and rolling. One more thing, and then I think we're rocking and rolling. But welcome, you guys. Put in the chat for me. Where are you joining from? What have you guys been doing? What are you up to for the holidays? I love to hear all of that. And get to know you guys. Today, we're going to be talking about test taking strategies. This is for APRNs, Advanced Practice Registered Nursing students. So if you are joining us on one of our pre-nursing or nursing channels, you're more than welcome to stay, but this content is going to be for advanced practice style exam questions. So if you have joined my webinars before, you know this is going to be highly interactive. I love for you guys to take out the chat box, whether you're on your phone or computer or however way you're joining, and just engage with me. That's really what I enjoy. All right, all these authenticator apps asking me, are you a real person? Yes, I'm a real person. It's funny. When AOL was a thing and it started to be a thing in college, and now don't worry about things. The real shows my age. Okay. Taking so something that I will share about what I'm doing with the holidays. So this morning we had a hot cocoa party at my daughter's school, which was so cute. They're all so cute. She's in first grade. And it's just wonderful to see the little ones enjoying the holidays, and then it's nice that the schools really engage the family. The kids still want you around at this point, which is awesome. See if this works. But for the holidays, we're in the Dallas area for most of it, and then we're going up to the Boston area, which is where my family is and where I grew up. So I love the Boston area. You see a lot of friends, hopefully. Everyone's busy for the holidays. Super excited to catch up, see all the kiddos grow. Well, most of my friends have little ones, so I got little technology on a Friday work for me. So let me see in the chat while I'm trying to get this to go. Where are you guys joining from? You guys, I think I made the tech work. I think it's working. Maybe so pumped. It's working. Yay! Okay. I can't believe that, but sweet. All right, let me pull up all these screens and see what you guys are saying in the chat. Welcome. Louder, please. Thank you for that. Okay, how's that? Is that better audio? Give me a head nod if that's better audio, yes or no. We can't hear you. Is that better? Can you hear me now? Thumbs up, thumbs down. Let's see. Same. Please, no sound. What about now? Is that better? Yes, no? Let's see. Okay. How about this, you guys? Can you hear me now? Thumbs up, thumbs down. See. Louder initially, can hear better. From Orange. Hi, Dominica from Orange County, California. I was just there a few weeks ago for the ACN conference in Anaheim. Welcome. Must be a Zoom issue. Yes. Now that's better. The volume is great now. Okay. Yes. Nope. Any better? It looks like yes on Zoom. It's better, but maybe not. Yes, I can hear you. Okay. It's working on Instagram and TikTok, but maybe not on our Facebook and YouTube channels. Yes, you're good now. Oh, yay. Okay. It sounds like everybody can hear me now. That's a win. Very good. All right, you guys. So like I said, my name is Hiva Kolodrubetz. I'm a family nurse practitioner. I've been in clinical practice for a little over 10 years now as an NP. Prior to that, about 3 years of pediatric nursing in community health. I knew pretty much right away I wanted to elevate my nursing career with advanced practice training. So I talk a lot about that with Morgan on her podcast. If you guys haven't checked out NP Pulse, you guys should. It's a really fun podcast to listen to, and it's really informative. But I just love talking to students about whether the nurse practitioner track is the right track for them or not, because it's not the right track for everyone. And then I love supporting you guys, not just sitting for your board's exam, but really getting the most out of your education and being able to really apply that into clinical practice. So that's my big thing, making sure that you guys are clinically ready. So that critical thinking piece, that clinical reasoning piece is really, really important. So when we talk about test taking strategies, which is the theme for today, we're not going to be talking about memorization. I'm going to be teaching you how to break down those really complicated clinical vignettes and then really identify those knowledge gaps that you need to go back and learn more in depth about. So that's really important. So the learning piece is really important because when you're in clinical practice, when you're on the boards, that clinical reasoning is what you're going to rely on. So you may not always know what's going on, but you will understand what is normal pathophysiology. This is it's going to be abnormal patho that you'll be able to identify, and what are those safety steps that you're going to take to really make sure that we're caring for our patients and within our community as a team, right? You don't have to do it all yourself. You have a team of clinicians in your community. You're not practicing. Well, maybe you might be practicing in rural areas. That's the other area I'm starting to get really into and learn about, is how advanced practice nurses really are seen globally and how we're regulated globally. So I'm really getting into the advocacy piece and regulation, all of that. So it's fun for me. And I know you guys will get there. So I'm looking at the chat. So tell me, where are you guys in your training? Are you guys new grads? Are you guys sitting for your boards or getting ready to sit for your boards? Anna says, not too much prepping, stoked. Put it on the calendar through June this month. Yes, we just put our calendar up for our free webinars, our one-day live reviews in 2026. So we have it scheduled out from January through June. It'll be myself and Morgan Boosie doing most of those webinars and doing the live reviews. And we don't know our summer plans yet because we have little ones. So keep an eye out. We'll probably update the July through the end of the year 2026 calendar closer to February, March, once we know those summer camp schedules. But I see Lily's on there studying for her FNP exam. Awesome. Anna's also FNP studying. Has it started yet? Hi, Michael. Good to see you guys. So too warm in Florida, so it does not feel like Christmas. I feel you, Anna. And so I'm wearing I don't know if you guys can see, but I'm wearing my Grinch sweatshirt today. But it's a little cold here in Texas, but it's not really like that snow, that white snow. And Lily says her name is Lillian. Very good. Taking class December 29th. Okay, what does that mean, Michael? You're taking the boards, you mean December 29th? Volume is great. Great, Dominica. I'm glad. All right. So it looks like, and then, oh, you're at term. Okay. We have some pre-nursing students joining today's webinar as well. So for those of you, because the volume I know was an issue in the beginning, those of you joining, it does not matter if you are pre-nursing or nursing and you want to stay on. This lecture is really targeted towards advanced practicing registered nursing students. So you guys are more than welcome to stay on if you're not APRN, but these are going to be really clinical vignettes for APRNs taking that APRN boards. All right, so let's jump into the content now that we all know each other and got all cozy. What I always like to tell my students is know the exam layout. You might have already decided which boards you're taking, and you might be thinking, okay, I need to choose. I see some students sometimes paying for both and signing up for both for a myriad of different reasons, but I personally would not advise that just because these exams, these board exams are really expensive, right? I want you to really pick one that you're going to choose long term. It's a community that you really want to be a part of long term. ANCC is part of the ANA. AANP is its own separate entity. Both have really great communities, but the exam layouts are a little bit different. So you really have to think about which community do I want to be a part of long term, and just pick one, choose one, and sign up for one. On a hiring end, when I'm hiring nurse practitioners, I'm not looking at whether they took ANP or ANCC. They both are board certifications, and they're both highly accredited. So don't panic about that. If you're taking ANCC, the exam layout varies a little bit. So this exam has a few more questions. You have a longer time limit for it, 175 questions. And typically you'll see a lot of single best response, multiple choice, but they also have those select all that apply, drag and drop, hotspot. So they do have those different formats in there. Even ANCC now is leaning more towards those single best response questions, but you will probably see those alternate formatting. And then what I wanted to point out is there's some rumors that go around. People are like, oh, those unscored questions out of that 175 are usually the first 25 or the last 25 or the middle 25. Treat every single question as if it's the real one, because we really don't know which ones are the test questions. AANP, so pretty similar, but 150 questions, 15 unscored. You get a little less time because it's 25 fewer questions. And it's usually just not usually, but it is just those single best answers. Everyone gets a score report, which is really nice. And ANCC, only those who do not pass get a score report so they can see those areas that they need to improve on. Also, those exam domains are the same, right? So as nurse practitioners, as advanced practicing registered nurses, we need to be able to assess our patients. We need to be able to diagnose what's going on, create a care plan that's appropriate, and then evaluate that care plan and see if there are any changes that need to be made. Always have those patients come back in for follow-up. ANCC has broken down a different domain called implementation, and you can see they weigh it pretty heavily. A lot of people say, oh, it's going to be all about professional role questions. That's not quite true. Yes, it does have those professional role questions. So you do need to get comfortable with your scope of practice as an APRN, but it's also including those non-pharmacologic as well as pharmacologic interventions. So those are things that we really talk about, and those are things that are going to come up on ANP as well. They're just not called the implementation domain. But it does focus a little bit more on more of those professional role questions like regulatory guidelines, scope of practice, legal and ethical implications, which I think are great. And as I'm getting more into advocacy, I think we really need to be teaching this to our NP students. So as you guys get out there, you can advocate for your role. And what I mean by that is you don't need to like jump into policy right away. I know there's a lot. It's a huge learning curve getting into practice, but knowing what your scope of practice is and being able to communicate that effectively to the admin who has no training in advanced practice and they don't know what's going on, you really need to say, hey, this is what my scope is. These are the regulatory guidelines. This is what we need built out in terms of processes in this clinic if you don't already have it. So, oh, very nice. We have some adult gerio primary care NP students graduating in February. That's exciting, Dominica. Lillian's taking the ANP. Very, very nice. So yeah, it's hard to choose. I remember that, but you're not going to make the wrong choice is the whole point. Those age distributions, I like to show this to my students too, because overall, whether you're taking adult, gerio, primary care, or family nurse practitioner, it is all going to be focused on what you're going to see in that outpatient primary care setting. So those age groups are really going to be distributed to mimic and emphasize what we're going to be seeing in real life in clinic. So think about that as you're studying. It's hard for a lot of nurses, especially experienced nurses who have been on the inpatient side. But when you're sitting in front of that clinical vignette, I really want you to be thinking, okay, Think about your setting. I'm in a primary care outpatient setting. What can I realistically do in this setting, right? We can't get stat labs. We can't get stat diagnostics. Maybe we have some point of care testing, but you are in an outpatient setting. So sometimes that means we really need to look at that patient spectrum of stability. Is this someone I can safely manage in that outpatient setting, or is this somebody who needs higher level of care? Okay. So I really want you guys to be thinking about that as you're going through these clinical vignettes. Some patients are going to be tough. They're going to be middle of the road. On the boards, I think it's going to be pretty clear whether it's going to be stable or unstable because they're not trying to trick you, right? They just want to make sure that you are safe, entry level safe as a clinician going out into the clinical world. So really thinking about, are these what makes a stable patient in that outpatient setting? So are these things that we expect to find, right? Am I expecting that my patient's going to be in pain and miserable with an ear infection, right? That's normal. But am I expecting that my patient's really going to be going south and maybe their conditions changing for the worse? That's more of an unstable patient, right? So we really need to be thinking about, is this something I expected? Is it something, or is this something that's unchanging and pretty stable? Or is this something that I really need this patient to be monitored more closely, right? With our aging population, with those infectious diseases, we really need to be thinking about safety. Safety always first. So let's break down the method that we talk about here at Archer that I use with my students. And I think it's really effective. It's the way I study, and I think it's really effective for students to understand where they need to go and focus a little bit more on that material that they don't know as well. So let's break down those clinical vignettes. What do we need to focus on? So the first thing I tell my students is, please just read through the whole clinical vignette. Sometimes students will get really anxious if it's a nice, thick, juicy clinical vignette, which I'm going to put a lot of examples up for us to walk through together today. And so they'll read through it really fast. And then my first question is, what is the question asking? Right? And most students won't know because they've read so much, it gave them so much information, they feel a little overwhelmed. So that first step is, once you've read through the whole case scenario, pause and see, what is that question asking? And if you don't know what it's asking, read that last line again. Because usually in that last line, it'll say what it's asking. It'll say, like, what's the next appropriate step in this patient's plan of care? Or it'll really tell you what that question is asking. So I want you to understand, what is this question asking, and be careful with the wording there. Is it a positive or negative, right? Is it what's the most appropriate, what's least appropriate, what's not likely the diagnosis? So pay attention to what it's asking. Then go back through the clinical vignette and read it line by line. And what I mean by that is really stop at the end of each sentence and say, okay, just like you want to be studying, you're not going to just read for the sake of reading. You're going to stop at each sentence and say, what were those keywords? What is the sentence trying to tell me, right? What am I getting? What am I thinking from this sentence? And how does that play back into what the question is asking? And you're going to do that line by line through the whole clinical vignette. I get students that get really nervous and say, Hiva, this is a timed test. How can I do that? That takes a lot of time. So if you're doing it with your studying, first of all, you're going to get faster at it. Second of all, you're not going to miss anything. And our QBank feature, you can time yourself. You'll see that realistically, it doesn't take that much time. So whenever we're anxious, we feel like time is moving really fast. So this is a nice way to really slow us down, make sure we're understanding what the question is asking, we're understanding those keywords so we can answer it with that clinical reasoning effectively, right? And it really doesn't take that much time. So when you're doing your practice questions, you should be doing this method every time. You're going to get faster at it, and you're going to get more out of your studying that way. And on exam day, continue to do it this way. You have 3 hours for ANP, 3.5 hours for ANCC. That's plenty of time. So we're not rushing through these questions. So step 2 is pulling out those keywords line by line. And then step 3, before even looking at the answer choices, answer that clinical vignette in your own words. And the reason why I say this for step 3 is because most students, when they get really anxious, they start self-doubting. They start talking themselves out of the right answer when they're starting to read the answer choice, and then they're fully confused. So what I always say is, answer it in your own words before you even look at those answer choices. And then go through the answer choices one by one and either eliminate the ones that don't line up with how you answered the question, or keep the ones that you're not sure about or the ones that do line up. And then when you're coming down to, if you have one or two left, make your best guess, make an informed decision, and don't overthink it and move on. You can always flag it and come back to it at the end of the exam. However, biggest caveat, statistically, your first instinct is always going to be the best. So if you talk yourself out of the question, if you change your answer at the end, statistically, you're more likely to get the wrong answer. So don't talk yourself out of the answer. Don't overstress. Don't overthink. Do your best and move on. It's just one question out of 150 or 175. All right, that was my alarm, but we started a little bit late, so we're going to keep going for a few minutes. All right, so clinical prioritization, we talked about that. So let's put it all together. Let's go through some clinical vignettes. And like I said, I love to hear from you guys. This is engaging. I want you guys to put it in the chat for me. So let's read through it together. Remember, step one, read through the whole thing. And what is that question asking? If you don't know, read that last sentence again. So go ahead and read the question, you guys. And while you're doing that, I'm going to make sure I'm not missing anything in the chat. So I see, Shanice, you're asking, do you offer these reviews for LVN and LPN students? Yes, Archer has both pre-nursing and nursing in addition to advanced practice. So definitely want to make sure you are checking out our page for those licensure exams. Good question. All right, let's see here. All right, Instagram, TikTok, what do you guys think? I see some students are saying joining from AVU University, third semester. Very good. Leo, Araman, Jada, great to see you guys. All right, so let's read through this together. And I'm not seeing any responses yet. So make sure you guys are putting your answer choices in the chat. So this is a 60-year-old male patient, presents to the clinic for a well exam. Patient has recently moved to the area from a different state and hands you lab work performed by his PCP 3 months ago. States that he has a history of hyperlipidemia, hypertension, stable hepatitis. Current medications include aspirin, atorvastatin, and lodipine. While reviewing the lab work from his old PCP, you notice that the patient's LFT, so the AST and ALT levels, are elevated. He expresses concern because he was started on atorvastatin 3 months ago by his previous provider. Which of the following is the most appropriate course of action? That was meaty, right? What the heck is this question asking? So step one, what is this question asking? Read that last sentence again. Which of the following is the most appropriate course of action? So they're asking you, what's the next step in this patient's plan of care? They're coming in to see you. What's the most appropriate for the nurse practitioner to do? Now we're going to go back line by line, pull out those keywords. 60-year-old male. He's coming in for a well visit, so he's feeling fine today. He recently moved to the area from a different state. He comes in with his lab work. PCP did labs 3 months ago. He has a history. They're telling you his chronic conditions. Wonderful. They're telling you his medications. Wonderful. Part of that medication is a statin, right? And you're looking at his old lab work and you notice that LFTs are elevated with statins. What are we thinking with that? So are we worried about this patient? Is this a patient who's acutely sick? Is this a patient who is stable or unstable? Let's think about that and put it in the chat for me. He expresses concern. So patient is coming in concerned. So we need to listen to our patients when they come in with those concerns, and whether we need to figure out if we need to reassure them or if it is something that's concerning to us as well. Remember, they don't have the medical knowledge. You might get a patient or two who does have a medical background, but even those patients, it's really hard to manage your own medical care. You don't really want to do that. You want to be able to bounce it off a professional. I do that all the time. I visit and say, hey, this is what I'm thinking. Am I being crazy? Am I not being crazy? So they are still in that patient seat. So this patient's concerned, right? Because he was started on that atorvastatin. This is a new medication for him 3 months ago by his provider, and he's worried about those elevated liver functions. So it doesn't tell you how elevated, but it tells you it's elevated. And then your answer choice is A, B, C, and D. What do you guys think? So Lillian's saying this patient is stable. She's locked in her answer. Anna's locked in her answer. Michael's locked in his answer. What do you think, Dominica? And then let's see who else in the chat. Okay, Judith is saying stable, stay on medication. What about you guys in Instagram and TikTok? You guys think stable, not stable? What do you guys think? Going once, going twice. Oh, Harbinder's throwing in. Dominica's throwing in their answer choices. Very, very good, you guys. Okay, so A is the correct answer. This patient is stable. So we would continue this atorvastatin at this current dose. And I always like to throw this in because I see a lot of students getting really nervous with those elevated LFTs. So many patients on statin therapy do experience an elevation in their liver function tests. It typically resolves spontaneously in about 70% of the patients. You don't have to chase it. You can keep an eye on it. However, caveat here, if they had given me those LFTs, they will give you a normal range as well. If the LFTs are 3 times more than the normal, that's when I'd say, hey, what's the golden rule there? What do we want to do with those LFTs? Put it in the chat for me, you guys. So do we take them off the statin still, or do we do something else? And I'm throwing something at you guys. I know. This is what I do. What do you guys think? But what's the golden rule? If we see a patient, LFTs 3 times more than normal, what are we going to get? Very good. We're going to get that liver ultrasound, right? I might repeat those labs and say, hey, let's see how it's trending. But if it's staying high, if it's staying more than 3 times the normal, then I'm going to get a liver ultrasound. Now, you don't necessarily have to discontinue or reduce the statin, right? What are we worried about with statins? So what is the biggest side effect that we worry about that would make us stop that statin and try a different statin? Or if we've tried a couple of different statins, patient's not tolerating it, we would switch to something like a PCSK9. What do you guys think? What are we looking for? Yes, that muscle breakdown. Very good. So we're looking for signs of rhabdo, right? How is it impacting the kidneys? Dark urine? Are they getting those leg cramps? Absolutely right, Anna. That rhabdo is what we worry about. That's when I would stop the statin, right? Make sure that patient's really well hydrated. I would try a different statin before giving up on statins, but then you also want to make sure you're treating that patient. You're just not leaving them at their own devices. So in this clinical vignette, we broke it all down. We answered in our own question, in our own response. So which of the following is the most appropriate course of action? This patient's going to continue on the atorvastatin, and I'm going to see probably this trend spontaneously resolve on its own. This is really mild, asymptomatic, patient's feeling well. So I'm going to reassure this patient. So we're looking through the answer choices. We're going to eliminate B because we're not going to make a dose adjustment. Eliminate C, we're not going to discontinue. Eliminate D, we're not going to discontinue. All right, going to the next one, you guys. You guys are doing great. Very good, Lillian. That's right. 54-year-old male presents to the clinic with acute shortness of breath and a sense of impending doom. This is a patient that came into my office, so I really like this clinical vignette because it's a real patient. He had right knee arthroplasty 1 month ago and just returned from a cross-country driving trip. His medical history includes hypertension, dyslipidemia, metabolic syndrome. He takes the following medications daily: aspirin, so he takes a baby aspirin, amlodipine, atorvastatin. He drinks 2 alcoholic beverages daily. He's smoked 1 pack of cigarettes a day since his late teens. Denies any illicit drug use. Physical exams normal. You suspect a pulmonary embolism. What diagnostic test will likely be used to rule out this diagnosis? Okay. That was a lot. What is this question asking you? Put that in the chat for me. I see some people are putting in their response. What is this question asking you? Locking in your responses. Yeah, so this question gives you a lot. And sometimes they'll do this, right? Because what they want to know is safety, 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 safety. So what's the diagnostic test that's going to help you, will likely be used to rule out this diagnosis, right? And it's telling you what you're suspecting, a PE. And absolutely, blood clot. Very good, Lily. And so we're thinking about this patient that is at risk. So let's go back line by line. 54-year-old male coming to the clinic with acute shortness of breath and that sense of impending doom, right? We need to listen to our patients. They feel that impending doom. Could be a panic attack, but we need to prove that it's not something more serious first, right? But it has that impending sense of doom. Look at his risk factors. If you pulled up the well score on your MedCalc app or you have it in your EMR, you can really score this patient and see what is the probability of a DVT. Look, recent surgery, right? Knee arthroplasty 1 month ago. Just returned from a cross-country driving trip. So sedentary, right? Long distance. He already has a history of cardiac issues that puts him at increased risk. Hypertension, dyslipidemia, metabolic syndrome. He is on aspirin, which is great, 81 milligrams, but that's not going to be enough. He does drink alcohol, which also does impact his cardiac health, as well as that smoking history, right? Look at his long smoking history. So that puts him at huge risk for blood clots, really makes the blood viscous. And so absolutely we want to rule out a PE. And then you guys are saying, yes, very good. B is the right answer. We want to get that helical CT to make sure that we rule out that PE. Now, in real life, you would likely be getting a Doppler ultrasound of his lower legs as well as a helical CT, because you would be ruling out multiple DVTs and a PE, which is what this patient ended up having. However, what did the question ask you? What diagnostic test will likely be used to rule out this diagnosis? What is the diagnosis? They say you suspect a PE. So we're looking for that diagnostic test specifically to rule out PE, and that's going to be our helical chest CT. Last thing I will say about this clinical scenario, is this something we're going to be doing in outpatient, giving this patient an order for a CT and saying, bye-bye, I'll see that order later? Is this patient stable or unstable? Absolutely, Judith. Rule out. Yeah, where are you going to refer this patient, Anna? Where's this patient going? So say the question was asking, what is the next appropriate step for this patient? And one of the questions were, hand them a order for outpatient CT, send them to cardiology, send them to the ER. Yes, this is an unstable patient. Very good. This patient is going to the ER, because remember, outpatient, if you send this patient outpatient, they're not going to get that CT same day. Likely they'll have to call, schedule. They'll be lucky if they can get it within a week. This is an unstable patient. This is life-threatening. Their breathing can stop if they have a PE, which is blocking the perfusion to the lungs, right? This patient had a large central PE and multiple DVTs. So this was a life-threatening issue, right? This patient went to the ER straight away to confirm or rule that out. So you guys are absolutely right. Very good. All right, let's do another one. This one, given timing, I'm going to jump around a little bit to see. Okay, well, this one's not as juicy, but let's start with this one. 62-year-old male presents to the urgent care complaining of severe left side headache with nasal congestion occurring every afternoon. Which headache type is the first differential? So what is this question asking? Put it in the chat for me. What is it asking? It's asking what's the headache type, right? You have a list of differentials. Headaches are going to be your nightmare as new grads. I remember I would get so panicked with headache on that chief complaint. I'd be like, okay, let's see what comes in. Because you have to make sure you're asking a thorough history, right? This one's telling you, okay, which headache type is first on your list of differentials? Let's go back and break it down. 62-year-old male, so he's at risk for certain types of headaches, right? He comes into your urgent care. He's complaining of severe left-sided headache. So he's describing it as a 10 out of 10. He's getting some concurrent nasal congestion. It occurs every afternoon. That's interesting, right? So it's consistently happening. It's persistent, right? So what are we thinking with this patient? What is at the top of our list of differentials? So Lillian says cluster headache. What do you guys think? What's at the top of your list of differentials? Harbinder is locking in his answer. Anna's locking it in. What do you think, Judith? Judith's locking in cluster too. Let's see. I see one more comment on there. Becky's saying migraine, left-sided. Yeah, this is a tough one, right? And so C is the correct answer. Very good, Lillian. So it's unilateral. It's intense. It's severe, right? Severe unilateral headache with that nasal congestion happening every afternoon. This is pretty classic cluster headache, right? So migraines usually are more of a slow to come on. That's why some patients get those auras. Some patients do have auras, they don't identify them. Some patients don't have any auras, but migraines are usually slow to come on. They can be unilateral, but they last a long time. So cluster headaches typically do happen more in our male patients. Doesn't mean it can't happen in our female patients, but typically it comes on really strong, really hard, really fast, severe, one side. And then there's also associated nasal congestion or tearing of the eyes with that. So absolutely, this is pretty classic cluster. However, if you're taking this question in our Q bank and you got it wrong, this is when you go back and you really think, okay, how does this present, right? What patient demographic is it most likely going to present in, because they're not looking for zebras on the board. And then you're going to think, okay, now that I know what's at the top of my list of differentials, do I know what the treatment is for all these different types of headaches? And really compare and contrast when you're going through. So what's the treatment? What's the best course of treatment for a cluster headache, you guys? What do you guys think? I'm looking in that chat. Come on, Mimi. Come on, Melanin. Margio. What do you guys think? What's the best treatment? Come on, Sophie. Oh, that's so fun. Oxygen, says Lillian. Very good. Oxygen, says Anna. Very good, you guys. Yeah. So oxygen is going to be first line. Also, calcium channel blockers really help with that vasodilation as well for this patient. Very, very good. All right, how are we doing on time? I can't stop. Let's do one more and then we'll wrap it up for the day. I put in so many of these practice questions. We'll do another test taking strategy webinar in the new year. Maybe I'll add one of those. All right, patient comes in for evaluation, bilateral eye irritation with that redness, tearing, itching. Patient has no other symptoms, no recent illness. On exam, there's bilateral conjunctival injections, no crusting, clear, watery drainage bilaterally. Which of the following diagnoses is most likely? So what's this question asking? Put it in the chat for me. What type of question is this? Very good, Judith. Oxygen, that's right. There's a slight delay on these socials, so you guys will answer it and then I'll see it a little bit later, but I really appreciate the engagement. It's more fun for me and hopefully it resonates better with you guys. All right, so this question is asking which of the following diagnoses is most likely, right? So it wants that top differential. So let's go back. Patient comes in for an evaluation. He has bilateral eye irritation. Pull out that key word, bilateral eye irritation with redness, tearing, itching. Sometimes patients will come in and say their eyes feel like there's something in it, right? It's grainy, this grainy sensation. No other symptoms, no recent illnesses. What does that tell us? Those are key words there, right? So if we're thinking about a certain type of conjunctivitis, we would think, okay, have they had any other symptoms? Have they had a recent upper respiratory infection, right? Do they currently have a viral URI? Hint, hint. On exam, bilateral conjunctival injections, okay? No crusting. What does crusting tell us? What are we worried about with crusting? Pus, right? Absolutely, pus with crusting. So crusting is really that pus that builds up. Patients sleeping, they wake up in the morning and they're like, oh man, I have to really take that crust off to open my eyes. And clear, watery drainage bilaterally. So most of you locking your answer, do you think this is allergic conjunctivitis? You guys are absolutely correct. Good for you. But why, right? Very good, Jazz. Why? Chippy, good job. Ariel, good job. Dilfuza, good job. Sorry, I'm not doing so great with these names on social media, but I'm sorry if I'm butchering it. So why, right? I always want to know the why. Even if you get it right, you should be exploring the why. So why is allergic conjunctivitis the right answer? We're pulling out those key facts. It's bilateral, first of all. We're looking at classic textbook. You can have patients come in not classic in clinic. We're talking about the board, so it's going to be classic textbook. Bilateral is going to be allergic versus viral or bacterial. Viral bacterial are usually unilateral in the textbook, right? Again, that's the caveat. No other symptoms. So if that patient had other symptoms, so upper respiratory infection, cough, sneezing, sore throat, I'd be more thinking, okay, this is unilateral, could be viral conjunctivitis, right? Pretty common. And then no crusting, no pus. So what's happening with the pus? That's your body's immune system attacking the bacteria. Pus is the debris from our white blood cells attacking the bacteria. So you're not going to get pus unless there's really a bacterial infection. And that's where the crusting comes in. So clear, watery discharge. They may have also told you this patient has seasonal allergies just to help steer you towards allergic conjunctivitis, but absolutely. And then being able to compare all that. And then molluscum conjunctivitis, maybe you know it, maybe you don't, but this is what your study plan should be focusing on. Identifying, okay, do I know how to compare these common things I'm going to see in primary care? How do they present? What's the treatment? How is it described in clinic, right? What am I going to be seeing in my patient? And then what's that appropriate next step for them, right? And what happens when they, the plan of care is not working for them, right? How do we reevaluate that? So remember, spend more time breaking down the questions. I tell my students no more than 25 to 50 practice questions a day, because you really should be taking the time to learn from those practice questions. Research shows that if you're learning something and testing yourself as you're learning it, like doing practice questions, it's going to resonate a lot better than if you just wait till the end after you've studied everything and then you're taking those practice questions. So practice those questions as you're focusing on those body systems, right? So 25 to 50 max a day in one body system. Identify those knowledge gaps, focus on those knowledge gaps. Do the same with a different body system. Look at just one answer at a time. So answer it in your own questions. Look at just one answer at a time. Rule it in, rule it out, make your best answer choice and move on. Don't overthink it. Practice regularly. So don't overdo it. I've had students who take 175 practice exam questions, exit exam questions a day for months before their boards exam. Your brain is burned out and oversaturated at that point. That's not going to help you. So practice regularly, but keep it realistic. Really, no more than 25 to 50 a day. You're going to start with 25 initially when you're breaking down those clinical vignettes. Maybe you'll go to 50 once you're really having fewer and fewer knowledge gaps to fill in. But this is really going to get you more comfortable for exam day once you're seeing that style of question over and over again. And lastly, don't be afraid to reach out, right? We have some great exit exams coming out by the end of this year, hopefully, or early January at the latest. And they're going to be free. So 2 exit exams that we just put together as a team. We're really proud of them. One for ANCC, one for ANP. So ANP has 150 questions, ANCC has 175, and they're free right now because they're in that beta phase. So we're really looking for students to test them out and collect that data so that we can really make them harder, make them easier, see what those difficulty levels are so that we can bring you a exit exam that's really going to help you feel confident going into exam day. We can say, okay, this is your score. You're going to, this is where you stand in your study plan. So keep an eye out for those exit exams. Look at our products. So these questions were pulled from our QBank. We have over 1,600 questions. You can filter them based on the type of exam that you're taking. It really goes through the rationale, links it with our video. So if you're not doing the Sure Pass, which gives you everything, you can do a combo pass, which links the QBank to the video. I highly recommend that, because if you're in those board style questions and you want to look at the rationale and want to look at the videos, you'll have to add that video on demand bank. Instead, if you buy it as a package, you'll already have access to it. And it's really nice because it goes right into that content in those videos. Our videos also have really nice assessment, full head to toe videos on how to do things like speculum exams or you to use an otoscope or your cranial nerve test. So it's really helpful, especially for those students really feeling like they need more help with those clinical skills. And then the board's power prep, this is new. We've done 2 of these now. This is a 1-day live review that myself and Dr. Boosie conduct, and it's really in 1 day. So 8 a.m. to 5:30 p.m. Central Time. We go over everything. We talk about the blueprint. We go through more test taking strategies. It's really interactive and engaging. So we go through all those different clinical vignettes as we're going through the subjects, which is really fun and helps you guys really remember it. You get access to all of the slides. It's over 400 slides, almost 500 slides, and they're really meaningful slides. They're beautiful in terms of illustration. They have the content, high yield content. This is what you need to know. You also get a workbook that you can use to really quiz yourself and see where are those knowledge gaps, and then you get the recording, access to the recording for 30 days. So I think this is a great option if you guys are getting ready to test for your board soon. If you're not there yet, you're still in that studying phase, you can always do the combo. But either way, this is my email, comes directly to me. My students will know. Anna emails me from time to time. I love seeing your emails. Even if I don't get to it right away, I will get to it, and I would love to help you guys out. So whether you want to meet for one-on-one mentoring, tutoring, if you just don't know where to focus your studying, please reach out. Community is the best way to get not only through your program, but really come out the other end feeling confident to go into clinical practice, which is our ultimate goal. But yeah, you can always just send me an email, a shout out too, and just say hi and tell me where you are in your journey. I love to see you guys see those recurring names and faces on the webinars. And I really appreciate your time. And I hope everybody has a wonderful holiday season, safe travels if you're traveling. And thank you for joining today. We will be back in the new year with all our wonderful free webinars and one-day live reviews. So check out that calendar. As Anna mentioned, it's up and running on our website. Thank you again so much, you guys. And you guys are the best. Happy holidays. Bye. You're so welcome, Judith. Thank you for joining and for all your engagement today. Same to you, Omega, Becky, Ken. Oh, you guys are so wonderful. Awesome job, Lillian, Anna, Harbinder, Mason. Very good. That's right. Clear, watery, no crust. Luciana. Very nice, you guys. Love to see your names. Awesome, awesome. Thank you, Delfuza. I hope I'm not butchering that. Awesome job, Corey. Sakshi, very good, you guys. All right, have a wonderful weekend. Hi, Lillian.